Delighted to introduce Jacqui Fletcher, whom I'm sure all of you know. Jacqui is Senior Clinical Advisor for Stop the Pressure Programme and Clinical Lead for Pressure Ulcers for NHS England Improvement and the National Wound Care Strategy Programme. And as you know, it's Stop the Pressure Week, and Jacqui is going to update us with what's been happening this week and really about the theme of Stop the Pressure this week. So thanks, Jacqui, over to you.
Thanks, Sarah. So good morning, everybody. It's still morning. I'm delighted to be talking to you about our Stop the Pressure campaign this year. And I'm sure you've already heard from all this morning's speakers about the importance of pressure ulcers. But I just wanted to put a few things in, some little facts and figures, to set into context why we've chosen the theme we've chosen today. And I'm sure it's no surprise to you all that pressure ulcers remain one of our most common harms and affect a huge number of patients across the UK. But when we think about who those people are, what I want you to think about is how wide the spread is and who this could be, and how that could easily be somebody that you know. Because those most at risk include patients where their mobility is limited, where there is severe or increasing physical disability, where there's increasing frailty. And that doesn't mean that people are old. You can have young people with frailty, and where care is multifaceted and complex. What's really important is that these patients are cared for across all health and care settings, and frequently in multiple settings. They move backwards and forwards across these all the time. They affect people with both physical and mental health, and they occur across all age groupings, from our very tiny premature babies right through to our end-of-life care settings. So we've chosen inclusivity as our theme this year, and I think in the past, we've kind of thought we're doing a great job about inclusivity, because probably for the last 7 or 8 years, we've done a huge amount of work focusing on skin tones. And that's been really important work. And I'm not saying that that's not been really good, because it has really raised the profile of the importance of different skin tones in the work we're doing. But inclusivity is about so much more. And our theme for this year is really about, are you really looking and are you really listening? Or am I really looking or am I really listening? And what I realised was I wasn't looking and I wasn't listening, because I had got very hooked up in that skin tones things without thinking. Inclusivity is about so much more. It's about recognising diversity. It's about giving choice and having equality and equity and respect for people with so many different ranges of things that matter when we're thinking about how we engage them in pressure ulcer prevention. If you remember last year, our focus was on every contact counts. And we had a great campaign. We talked about connecting and communicating and adjusting and challenging ourselves and having good outcomes. But that only works if you make it count, if what you do has an impact. Because if you do what you always do in the same way that you always do it, it will work for a lot of people, for a lot of patients, for a lot of colleagues. But there will be some that it doesn't want to work for. So what we want you to think about from this campaign is how often you are doing these really simple things. Do you need to adjust your communication style in certain instances? When you're delivering information to patients, when you're delivering information to colleagues, do you think about if you need to do that in a different way? Do you think about if you need to simplify your message? So the really common example might be that when we're teaching, we always talk about pressure ulcers. But if you're talking to a patient, you'll think about the language they're using. You might say pressure sores, or if it's what they say, you might even say bed sores. And that's fine if it engages them, but we need to think about what their language means. And we also might now need to think about the environment, and that background and environmental constraints can be very distracting. And when we started the campaign, one of the questions we got, and we always get this, is who is our audience? Is this campaign about, are we really looking and are we really listening to patients? Or is it, are we really looking and are we really listening to our colleagues? And for me, the answer is both. And it's about making us think about it's not just the easy read option. And I'm going to use an example here, and this is a lovely document, so please don't think I'm saying that it's an easy read document, so it's not good, because I think we need to think about why we're doing things. So sometimes We do an easy read option because we think we've got some people that it matters for. So if you have an easy read example, and within that one that I just showed you from the Northern Care Alliance, it's very visual, it's got pictures, it uses symbols that people recognise, like the traffic light system, to talk about the level of risk. And when you create these documents, you might be doing it because you work in an area where you have a lot of people whose first language isn't English, and therefore this is very visual, it's very easy to work through. It might be that you work in a very socially deprived area where the reading age is low. But also think about how many older people do you have, and I'll put myself in this category, where if the text is too small, it's really difficult. Think about your older patients you work with, how many of them read with a magnifying glass? And that's quite labour intensive, and it's quite mentally intensive as well. So if text is very dense, it's very difficult for them. You might also want to think about where comprehension is poor. So whether that's people with a low intelligence generally, or people with a learning disability, or people with dementia, or you're dealing with children, there are lots of reasons why doing something like this might make life easier. So what we typically do, and we've got some really great examples on the Society of Tissue Viability Stop the Pressure webpage, is we think about particularly that non-English speaking, because this is a big population group. And what we do is we translate our resources into lots of different languages so that we're giving consistent information in a way that those people understand and that perhaps we can be culturally sensitive about. But I just want to go back to this really lovely pictorial version of pressure ulcer prevention. And in it, it's described as a picture guide to pressure ulcer prevention to aid inclusivity and delivery of information for a range of needs. And when I was talking to Holly, who made this document, it really made me stop and think, because I thought, why do we have to have a different document for people who are special? Why do we have to have a version that we say to people, and because of what's wrong with you, or because of the difficulty you have, we'll give you this? Why don't we just produce information in a way that it's accessible to everybody? And I want you to really think about that. Think about the amount of time and effort you put into translation of things, into making different versions of things. Whereas if we put that much time and effort into making things available and accessible and relevant for everybody, then it might be a better way round the system. The other thing that I've realised, and doing this campaign has been a massive learning curve for me, is that I really don't know much about things like neurodiversity. And I don't know what I need to do about it. So I know it's a thing, I know there are lots of websites about it, but I didn't really understand even the language, the terminology. So I didn't know the difference between neurodiversity and neurodivergent, for example. So you can see here that neurodiversity is the overarching framework describing the population as a whole and saying, which shouldn't be a surprise to us, we all think differently. The neurotypical describes the majority group, the people that perceive the world and learn and express themselves in what we perceive to be normal. But that doesn't mean that that's normal for everybody, because those that are neurodivergent think, listen, learn, express themselves differently. And that can be expressed by their neurotype. And there are lots of different neurotypes. And what I'm increasingly coming to understand is that people can have one or more of these. They can be on a range of these different things. And different forms of communication really work and really help people who have this identification. I think if we go back 10 or maybe even 5 years, it was very difficult for people who had a neurodiversity to be open about that because it wasn't common language. But some of you may be aware that we recently had our big wound care conference in Harrogate, and we did a session there on neurodiversity, and we did a poll, so a bit like you just did the Slido poll for you, and we just asked them, we asked the audience, how many people, and bear in mind these are clinical staff, identify as neurodivergent, or work with colleagues who identify as neurodivergent, or work with colleagues they suspect are neurodivergent but haven't identified in that way, or they're not and don't work with anybody. And you can see that bottom group is really small. So we're increasingly coming to understand that not only do we have patients with particular needs, but we also have colleagues with particular needs, and we need to be much more aware of that if we're going to get the best from people. I think there are more common things to think about. So there are common things when we're communicating with people that we might be much more aware of. So if you're dealing with somebody who's blind, you know straight away generally that you need to do something about it, or if they're deaf. But we also need to think about, so for example, one of our colleagues has an information leaflet on pressure ulcer prevention that's translated into Braille. And my question was, how does that get translated? And I think our understanding is it just goes to somebody who uses a Braille typewriter and they type the words from the leaflet and it comes out in Braille. But if the words in the leaflet say, look at your skin, and the leaflet's for somebody who is blind, that's not really helpful, is it? We also need to think about things like impaired vision might be dependent on the environment you're in or the time of day. So, how light or bright is it? Or people's eyes get tired towards the evening. And it's the same with hearing. Is that very situational? And then I kind of thought, well, these are things that we're talking about for patients, aren't they? But actually, when you think about it, so this is an example from a clinical group that I'm involved in, and I'm sure they won't mind me sharing this. This was a query from a specialist nurse saying, has anybody got experience of using hearing aids and doing ABPI for their Dopplers? And what really surprised me was the number of other clinicians that replied and said, oh, yes, I have a hearing impairment, and this is my solution. This is how I work round so that I can do the best for my patients. So when we're thinking about these day-to-day impairments, don't just think about patients, think about the clinical staff and colleagues you might be working with. Also think about the environment and the situational needs you have. So if you are talking to a patient and their family or patient and carers, or even if you're talking to clinical colleagues, you're trying to do some one-to-one teaching, some bedside teaching, actually, that is very much influenced by the environment and the situation. Background noise, if somebody has slightly impaired hearing, can blur or lose their focus. And for people who have some neurodiversities, noise can just be too much for them. It can become the thing that stops them focusing and concentrating. But equally, we know that some noises can be soothing. Lighting can be a huge source of distress. If you've ever had that really bad headache and the lights are really bright, you know how distracting that is and how you can't concentrate at all on what people are saying. For others, strobing or flashing or particular colours make things really difficult to read or focus on. So think about the colours, the typefaces that you use in your literature, and general distractions. Particularly when we're talking to patients and their families, think about when you're trying to engage them in preventative activities. What's just happened to them? Has somebody just told them some really bad news? You've just had a major heart attack or you need some big surgery, and you're going straight in to say, oh, and by the way, you're at risk of pressure ulcers and what I need you to do. They're not listening. They're thinking about what was told to them. And if they've had multiple things happen already, then they're really not in a situation. Equally, if they're in pain or distressed or just absolutely exhausted or quite confused, then you're not going to get their engagement. So what can we do to help? How can we help support you, support your patients and carers and your colleagues? Well, you may have already seen some of the great resources we had. So on Tuesday this week, we had an amazing webinar looking at speaking to people or working with people with learning disabilities. And we were really fortunate not just to have it led by Jeannie Donnelly from the Society of Tissue Viability, but also some learning disability specialists and somebody who worked with children in schools with learning disabilities. So remembering again that thing about it crossing the ages, and it's not just about people being in healthcare. There are children in schools with particular needs who are very at risk of pressure ulcers. We've again got a webinar tonight on focusing on people with dementia. When you're dealing with people with dementia, that's a really complicated thing. Their focus can be good for parts of the day and shocking at other parts of the day. How do you manage that change in their comprehension? How do you do things with them? that doesn't scare them or increase their anxiety levels. So we would encourage you to join that. And there's lots of smaller resources. So for example, you can see something here about hearing loss and what that means. 1 in 3 adults have some form of hearing loss. So if you're communicating with somebody who you know has hearing impairment or special needs, think about how you might start that communication. Firstly, making sure that they're actually paying attention to you, that you're facing them and they're facing you, and that you've got appropriate lighting and so on. Use the resources that we've got. So you can see here, we've got some fabulous videos in Makaton, and I tried really hard to stop it at the bit that says stop and the pressure. But these can help with some people who have some learning difficulties, where you're not just using vocal information, but you're using visual cues as well to help them understand what you're saying. And we have some really fabulous videos that you can use in that situation. But I also said this is about thinking about us as clinicians. How do we learn? And if we think about us as clinicians learning, we might also think about how our patients learn. So think about patients and colleagues might have very different ways of looking, listening, and learning. And I just want to give you one small example. So I was looking for an image of a patient sat badly in a chair, and I found this in the Daily Mirror. And it's a very typical newspaper article. So just to point out straight away, this is something I'm sure many of you have seen. This really unfortunate gentleman had a stroke and he was taken to A&E. Now, according to the Daily Mirror, he was 95 or possibly 97. So, you know, we have to be careful with the reporting. But just as you look at that, I don't know about you, but I'm thinking straight away, oh my goodness, he's slumped in that chair. He looks really uncomfortable. He looks really unwell. He looks really frail. But his bottom, the shear forces going through his bottom must be horrendous. So how do we teach other people about shear forces, whether that's family, whether it's patients themselves, or whether it's clinicians? So I just wanted to share some examples of how I teach shear and for you to think about which of these works best for you. So depending on who I'm teaching, I might be quite technical. So I might start with terminology, trying to explain to them some biomechanics, thinking about what those mechanical forces are and what you might be looking for and how you might measure them. So talking about the difference between a shear force and a shear strain, and that it's a physical force and what effect that has on material properties. And I can think that some of you straight away are absolutely not interested in that. That's not clinical. It doesn't mean anything to you. So sometimes I substitute it with some diagrams where I try to show how shear forces impact on tissue. So here you're starting to see something a bit more clinical. You've got bone and muscle and fat and skin, and you can see them moving, and there's a little bit of description about something you might know a bit more about. It starts to talk about friction. We understand friction. Does that help? And you can then see where the shear fits because this patient's on a support surface. With other groups, I do it very differently. So we can talk about what physically happens with the patient. We can show a little diagram of the skin, and I give an example of how you yourself might be able to feel shear. So if you sit in your chair and you stick your hands under your bottom and feel the bony points of your pelvis, and then kind of slump in the chair, what you'll feel is the bone moves forward, but your skin stays in the same place, a bit like in that diagram. So what you're seeing and feeling is the physical effect of shear forces. You can see and feel what's happening. And then more recently, what I've started doing is using this. So this is a video showing what happens when the patient's skin stays in one place. But as you sit the patient up, look at what happens inside the tissues. You see the bone moving, you see the fat moving, you see it all changing shape, changing position, that bone compressing down as the muscle, but the skin is still there and it's tucking up. So I don't know which of those worked best for you. I don't know which explanation of shear worked, but what I hope you thought about was the difference in the way of explaining those things. I hope you thought about the use of text, the use of language, the use of imagery, the use of clinical examples, and the use of that element of doing it for yourself, feeling it for yourself. So when we are trying to give information, when we're trying to impart information in a way that it is meaningful for people, whether that's a colleague or a patient or a family member, you might need to think about what they need, what helps them. Go back to what I said about that pictorial leaflet. Should we be thinking about something that's impactful for all rather than having multiple versions? Because when we think about why does inclusivity really matter, I want you to go back to this picture, because in all my teaching for nurses, one of the things that I know works best is patient stories. If I do a presentation and it doesn't have a patient in it, if it's about tissue viability and I don't show wounds, I am far less likely to get engagement if I just show text and I just show diagrams. I'm likely to hold their attention for longer because text and diagrams are very intense. They require a lot of thought. They require a lot of consideration. So when we look at this picture, I want you to really look. I want you to really listen to what I was saying. What do you see in this picture of this patient? Forget that it's in the Daily Mail. Imagine that this is in your clinical situation. Look at that gentleman. This is a real person. This is somebody's dad. He was somebody's husband. He might be somebody's brother. He's a granddad. He is looking his age. You don't need somebody to tell you his medical diagnosis for you to be able to understand that he has considerable frailty. He can't even sit himself upright properly. And that's not just that he's asleep. How many people do you know that you could just put the blanket on like that and they wouldn't fidget it into something more of a comfortable position? What are you seeing in terms of how well he is supported? Look at that chair. Is that good equipment that we're using? Is it appropriate for him? Look at the environment that he's in. He's clearly in this situation in A&E, but he's just pushed against a wall. He's slumped, his feet are probably sat out in the middle of the floor. Somebody's going to trip over him. And it just makes you really think, were people looking and listening to that story? And what's frustrating is this is not an uncommon thing. And it's not that every day we go to work to do a bad job, but in the day-to-day busyness of our environments, we sometimes overlook things. What we see, if we glance quickly, is, oh, that's okay, he's asleep, he's resting. He's on what looks like possibly a comfortable chair. It's quite padded, it's quite wide, he's got a blanket over him, so maybe he's warm. But actually, if you stopped and looked, would you, as a clinician, as a carer, would you be happy to walk past that gentleman without stopping and making some adjustments, without waking him and making sure that he is okay? When did somebody last look at his skin? Has he eaten? Has he had something to drink? Is he warm? Is he comfortable? Is he in pain? Do you think maybe he should be on a bed, not slumped in that chair? So what I would ask you is to, every time you see something, think, is that the standard of care that I accept if I walk past it? Because if you walk past and don't do something, it is the standard of care that you accept. You really need to think about, what else can I do? Because I have looked, I have seen that, and it's not the standard of care that I accept. I would want to talk to that patient and their family and see what I could do. I would want to talk to the staff to say, what can we do? What can we as a team do to make something better for this patient? Because to me, this is not an acceptable standard of care. We need not just to do better for that patient in general, but we need to do better for that patient's skin. Because in order to prevent pressure ulcers, we need to recognise every time there is risk. And to do that, we need to be very aware of what is happening for that patient. So, in conclusion, I hope you understand why we really want to champion this cause of inclusivity. It is so much more than thinking about the colour of a person's skin. It is about really looking, it's about really listening, and it's about really learning, because I know for myself and for the whole team of us who've been involved in this particular campaign, we have constantly said every single meeting, I am learning so much. I didn't know this. I know I can do better. And I hope that really motivates you to go away and think about what you can do if you really look and you really listen. Thank you.
Thanks, Jacqui. That's absolutely brilliant. Yeah, comments in the chat there, about it being quite a powerful presentation. There's no specific questions as such, but I'm just wondering sort of how we go forward with this. I'm just thinking about education, because this doesn't just apply to pressure ulcer prevention, does it? This is what we should be doing anyway in any part of any area of healthcare beyond tissue viability, but it's not happening. I don't know what happens in curriculum in terms of training. It's not just nursing, is it? This is because we've got a multidisciplinary audience here today. So how can we improve this? How can we be, thinking differently, asking the right questions? Is it about collaboration, learning with, collaborating more with maybe learning disability services, mental health services? I don't know. How do we move this forward?
I think it's a really difficult question, Sarah. And one of the things that we were very aware of, it's a bit like when we started the skin tone bias thing. It's quite political, and people are constantly afraid of saying the wrong thing.
Yeah.
You don't want, people are worried that what the other person hears is, are you stupid? It's a bit like the question, if you see somebody you haven't seen for a long time, and if it's a woman and you go, oh, when's the baby due? And they just say, I'm not pregnant. It's that kind of social trip up that you don't want to do, isn't it? And what we talked about is how you have compassionate conversations, how you approach somebody to say, what works best for you? How can I help you? So if you frame it instead of what's wrong with you as what can I do, then people tend to receive that message in a much better way. And I think it is just this message about looking and listening. If you spot somebody really struggling, you notice patterns of behaviour. When I used to work at the university, simple things like dyslexia, once you've read somebody's assignment several times, you would pick up quite quickly the patterns of writing and not mistakes, just the way they put words and sentences together, and you could have conversations with them about that. But watch how your colleagues work. Do they need to take breaks? Do you see them disengage because they can't take in any more information? Think about when you're dealing with patients, just that situational environmental thing. We just need to be a little bit kinder, a little bit more considerate, I think, in general.
Yes, and it's sort of sometimes we overload with information because we feel we've got to get that information to a person. But, even a lot of people just find that overwhelming. But particularly if patients are in pain or they've got other conditions, they just can't cope with it. So it's about how it's delivered in a different way, isn't it? Certainly.
Yeah, is important, isn't it? Just give them one piece of information.
Yeah.
And what was really clear in the learning disabilities webinar, if you haven't heard it already, is we have to be more patient. You have to lead people to things. So there was a really good example. Johnny gave an example in the video of where somebody is resistant to something. They're not deliberately being difficult, but it's about finding what engages them. So this was, remember, this is in school children, and they were trying to apply cream to this child, and the child didn't want the cream. There was nothing wrong with the cream. They just didn't want cream putting on their skin. And first of all, they did we'll put it on us, we'll put it on their friends. And then actually what they did is they made it into a game, into a song, and they created a song about putting cream on. And actually it became something that the person quite then enjoyed. Now, I'm not saying we can all make songs up and do that kind of thing, but it is about that creative approach and not seeing it as a barrier, but seeing it as something we need to work our way around.
Yeah, and I think many of us can be quite creative, but you need the headspace to do that. And everyone just feels, complete overload. I'm just, thinking about that scenario that you had there, the guy in A&E, and I'm sure, yes, there were multiple people of all different roles that passed him because that is the norm because A&Es are overloaded and all the rest of it. And I think some clinicians maybe feel powerless or it's become the norm. But we do have a responsibility to challenge that and speak up about it, that it's not acceptable. But people sometimes feel uncomfortable doing that, don't they? They'll get labeled as difficult or whatever, but we should do.
Yeah, and it is. I'm not saying this is easy, and as I said, it feels uncomfortable. It's very wearing. So somebody's put it burns you out.
Mm,
In
mm.
the discussion we had at Harrogate, one of the things we talked about was this political sensitivity. So if you are working with people, so the example I always give, because this works for me, is say you're a night staff and you go to do handover in the morning. By the end of your night shift, you're quite tired and maybe a little bit tetchy. But the person you're handing over to has declared that they have a special need, a requirement, and they can only take 2 patients at a time, and they have to take a break to process that information. As the night nurse, I'm just thinking, oh, for goodness sake, come on, I want to go home.
Mhm.
I accept you've got a neurodisability, but it's just making more work for me. And I can see how that thought process would happen because everybody's really busy.
Mm.
But unless we work to people's strengths, so that might be what you see as a challenge, but that person might have some other really fantastic skill that, if you knew about it, would work really well. And we need to be team players. We need to work to people's strengths and we need to be kinder to others. And I think that's really important. We need to be kinder to others and to ourselves. So if you are somebody who hasn't declared they have a neurodiversity, talk to your colleagues about it. I know it's not easy, but maybe they'll be kinder to you.
Yes, and I'm glad you brought up about it's about our colleagues as well, not just about patients, because I've had examples, being aware of scenarios, and you brought in the hard of hearing and the ABPI. I mean, that is a real problem, because people then get frustrated. Oh, she can't do it because she can't hear them. Well, actually, there should be something in place to enable that. The same with patients have said, oh, that nurse has come in and she's not. She can't hear me, so why you bother sending her? Well, how awful is that? So people, again, should be supported and there should be some understanding. So it is very much, the staff as well as patients. So I'm glad that's been raised in this campaign.
But I think it's a two-way thing too, Sarah. This has really influenced me. I'm really passionate about it. And I was talking to my girlfriends about um, the example about the deaf nurse. And one of my friends, I saw her body language. She sat back straight away, and she just said, "I would hate that. I would hate a deaf nurse." And I was really judgmental. I was like, "Oh, for goodness sake!" And then she went, "No, you don't understand. If I think she's lip reading as well as listening, and I'd forgotten because it's one of my really good friends. It's not something I think about. Helen has a really bad stutter." And the thought that somebody was watching her lips,
Mm-hmm.
the hear, I couldn't cope with that. It would make me so nervous. I would not answer things. So we have to think of it in the round, don't we? It's
Yes,
everybody
yes,
involved and engaged. And
yeah.
it's bad for the person. We don't want to upset the deaf person. We don't want to upset the person with the stutter, but we've got to get good communication. And that's the bottom line is unless we communicate effectively, we won't affect change. And we need
Yeah, absolutely right. And comments here about kindness, which is, absolutely true. Jade saying, someone once told me it's not just making space for people who are neurodiverse, it's about welcoming and wanting them there. There is a big difference between awareness and acceptance.
absolutely.
Yeah,
I
yeah,
think acceptance takes time, doesn't it?
it does. Yeah. I don't think there's any more questions. It's been a really interesting presentation and conversation discussion. I think there's a lot of food for thought. People are saying that, obviously they need to think about this and their own approach to things. So yeah, thank you, Jacqui, and thank you for all your input into the Stop the Pressure campaign. There's been a fantastic week so far. More to come. Yeah, thanks for all you do.
Okay,
Okay.
no worries. Enjoy the rest of the day. Bye bye.
Okay, bye bye.